May I invite Dr. Zai KELKAR to talk about Exotropia and later to be discussed by Dr. Varsha Pandey. Hello.
So, good morning everyone. With permission of the chair, I would begin. So the talk is intermittent exotropia treatment strategies. So for goals of surgery is to restore alignment and to restore or preserve the binocular function. So what are the criteria? Reduction or loss in stereo acuity at near or distance, deteriorating fusional control, large angle deviation or combination of the above, or an increasing tropia phase are the reasons why we would wish to step in and operate. However, the optimum time of intervention is unclear because in children, early surgery is indicated to prevent progression to constant exotropia, and you want to you have a chance to restore the bifoveal fixation. While in adults, surgery can only help to achieve the orthotropia, but not bifoveal fixation. So it is based on surgery is based depending on the type of the exotropia. So if it's a basic type of exotropia, the deviation for distance and near is same. So unilateral recess resect surgery is recommended. And why is that? Because surgery on one eye was found to be more effective, 82% success rate, than surgery on both eyes with a 52% success rate. If it's a divergence excess type of exotropia where the distance deviation exceeds the near deviation, then a symmetric lateral rectus recession is recommended. And why is that? Because bilateral lateral rectus recessions would affect the distance deviation more than the near, and a recess resect procedure would affect the distance and near deviations equally. If it's a simulated divergence excess, then many patients with an apparent divergence excess type would manifest an increase in their near deviation after 1 hour of monocular occlusion. So surgery should be performed for the largest angle that is measured. Kushner then came in and he subdivided Burian's classification into an excess of divergence or an excessive accommodative convergence. And so they believed that these patients had a near deviation that equaled the distance deviation, but it was masked by fusional vergences at near. So they recommended that it should be treated like a basic type of exotropia, that is the recess resect surgery. Again, when do you operate bilateral? When is it unilateral? So a long-term study, about 2 years, survival analysis of bilateral lateral rectus recessions versus unilateral recess resect for intermittent exotropia showed that although the surgical outcomes were comparable in both the groups, the final outcomes were better in the bilateral recess resect group, bilateral recession group rather than the recess resect group. How do you decide the surgical dosage and the age? So in younger patients who are less than 7 years of age, in whom the surgical dose was reduced, there was no significant change in the success rate as compared to those who had surgery using the standard tables. So standard tables are good for even patients less than 7 years of age. Abrams have proposed that patients may achieve a superior sensory outcome with motor alignment before 7 years or less than 5 years of strabismus duration. There are also reviews that the surgery needs to be postponed for several years because intermittent exotropia can still fuse, and hence bifixation can be obtained even if they are operated later, provided the orthoptic exercises are going on. And after all, not all intermittent exotropias are progressive. About age, the deviation may remain stable for many years, but in some cases it may even improve. So some researchers thought that the patients might easily achieve a binocular function if operated after 7 years of age and even over 5 years of duration. So favorable results after surgical intervention before 2 years of age also have been reported in literature with good percentages. So what is a good indicator for deciding to operate? So it is definitely the increasing tropia phase. So because this indicates a deteriorating fusional control. So progression should be monitored, home monitoring as well as clinic monitoring, and the increasing tropia indicates that there is diminished control and definitely there is a potential binocular function loss. So you should be operating. Sharma et al. Have proposed that distance stereo acuity as an objective measurement, and that indicates the time to intervene surgically. Success rate will depend on the length of the postoperative follow-up. Longer the follow-up, the better, then you can pick up the recurrence and you can actually treat it. And in recent studies, success rate has been reported to be about 60 to 70% in intermittent exotropia. Undercorrection is a pretty common thing that we see after initial bilateral lateral rectus recession procedure, and it can require a second procedure in 20 to 30%. use of basin prisms of power greater than residual deviation has been advocated to provoke conversions, but I have no experience in that. For overcorrection, the surgical overcorrection can vary from 6 to 20%. Of course, you have to wait and watch because immediate surgery or immediate intervention for overcorrections are not recommended. And the second operation should be, if at all, should be delayed for at least 6 months, after which then you can decide. In older patients, that's patients more than 12 years of age, in whom the surgical dosage was increased, there is a statistically significant increase in success rate. That is 80% versus 41% for the standardized tables. So modifying surgical dose according to age can improve the success rate in intermittent exotropia. Post-operatively, of course, orthoptic exercises, synaptophore exercises can be administered. Diplopia can be seen in patients who are essential alternators or who have large angle deviations, and patients have to be counseled accordingly. So to conclude, the preoperative deviation is one of the strongest predictor for favorable surgical outcome. And surgery with preoperative orthoptic occlusion or therapy has had the highest success rate. Children receiving surgery at young age may develop better postoperative binocular vision. Postoperative synaptophore exercises, amblyopia therapy can help restore the binocular vision. And short-term studies with 6 months to 1 year follow-up report a success rate of 80%. 2 to 5-year-old studies report a success rate of 50 to 60%. But literature review suggests that most studies will help us understand the pathogenesis of intermittent exotropia and understand the behavioral pattern of the disease, which will help us to treat it better. Because all said and done, there are also papers which say, does intermittent exotropia ever get better? So people can still, once an exotrope, always an exotrope, also is seen in a few patients. Thank you.
Thank you, Dr. Jay, for the wonderful presentation. Dr. Varsha is there for discussing? Yeah. You want to add?
Good morning, everybody. Very nice presentation, Dr. Jai. It's a vast topic, really. And a few points just I would like to mention that as we all know, it is a very difficult condition to manage. The ideal approach for the management of intermittent exotropia is still a challenge because there are so many other factors. The etiology is not very well known still. The neuromuscular factors, genetic, hereditary, and the fusional problems. So all these factors make it as a difficult condition. And so a defined long-term prospective studies are also not there. Most of the studies are there for 2 to 3 years. So most of the time the recurrence or the residual squint is seen after a long gap of 4 or 5 years. The drift is seen after 4 or 5 years. So again, that becomes a difficult condition to treat. Coming to the treatment, there is some role of non-surgical treatment also. Non-surgical modalities also helps in treating intermittent exotropia. We all know that it is not curative, or it won't correct the condition totally, but before surgery we can give a trial of orthoptic exercises, has already been discussed, to treat these intermittent exotropias. It is because it is non-invasive, and the specific indications for this non-surgical treatment, that is to reduce the symptoms. If patient is having asthenopia or diplopia, blurring, so it can help in initial stages. Then it will enhance the ability to fuse, and it will reduce the angle of deviation to some extent. So just to postpone the surgery also, it can help. So there is some role of non-surgical modalities in the treatment, and the orthoptic exercises has been already discussed that topic. So we can give anti-suppression exercises to improve the fusional range. There are many softwares nowadays, so that will also help in improving the fusional capacity of the patient, so that post-surgery also it will help. And coming to the surgery, again it is difficult to decide at what time surgery to be done, and everybody knows that early surgery always gives better results, but early means how early, that is again a question. So Dr. Zai has already mentioned before 7 years of age and 5 years of strabismus duration. So these 2 points help us to take the decision of the surgery, which will give superior sensory outcome and good motor alignment. Newcastle score and deterioration of the distant stereo acuity will help us in taking the decision. So these parameters should be checked regularly. And coming to the surgical procedure, RR procedure and bilateral LR surgery, again these two procedures are commonly done, and bilateral lateral rectus recession is always preferred to avoid the inducing lateral incompetence and to prevent the palpebral fissure changes. But again, the surgeon's choice is there. So depending on the angle of deviation, if it is more, we have to do unilateral RR surgery to have a better effect. So again, one more point I would like to have opinion about this use of Botox injections in intermittent exotropias, if anybody in the audience is doing. So there are few studies, Botox in both the lateral recti, 2.5 units, and that gives better control of deviation. And the long-term effects again are not known, but there is one study which shows 70% of the patient have shown good fusion for a period of 2 to 3 years. So again, that is one modality available to get it done before surgery or to postpone the surgery. So thus it is a very difficult condition to treat, a great challenge for the challenge for the surgeons. So proper counseling of the patient, the incidence of recurrence re-surgery should be explained to the patient to have a good outcome of the patients. Thank you.
Thank you, Varsha. That was a very nice discussion. Any questions from the audience? A question from the audience?
Yeah. Hi, ma'am. Thank you for all the information. I am Dr. Partho Bakshi, cornea surgeon. So, when you have an intermittent exotropia along with a refractive error and the patient wants to undergo a LASIK, what would be your preferred approach? Getting the squint surgery done first or the LASIK surgery done first?
So that's a very good question, because we often face this in our clinical scenario. Now, since we operate LASIK is indicated for patients after 18 years of age, that is when the number has stabilized. So usually when the number stabilizes, the deviation with or without glasses is also going to stabilize. So when the patient wears glasses and still if there is a deviation, say exo or iso, any deviation, for these patients we recommend that they get their LASIK procedure done first. We wait for a period of about 3 to 4 months, reassess them for their deviation, and then do the squint procedure as required.
You can also put a contact lenses and see
Yeah,
the amount
contact
of
lens, yeah.
deviations, because the contact lens mimics the LASIK surgery. So you can put a contact lens and remeasure the strabismus and see. So it is, yes, well, as she said, the LASIK should be done first. Yeah.
One point I wanted to ask, in children, those who have exotropia, they present to you at the age of 2.5 or 3 years,
Yeah.
doing surgery in these cases could be slightly risky. You get some
Yeah.
correction, there's a monofixation. So have you tried over minus?
Yes. Minus lens therapy, yes. About 1.5 to 2 minus power definitely helps. Many patients achieve fusion with that.
Yeah,
Yes.
over
So that
minus
is
lenses
one
can
over
help.
minus glasses.
But mainly, yeah, up to -2 we can give.
-2,
Because then the
1.5 to
children
2.
accommodate
Yeah.
and then they see clearly. Yeah.
Yeah.
Yeah, high AC by ratio, where the control is very good for near.
Yeah.
So yeah, because if you have a congenital, like a constant exotropia, it doesn't work. Yeah. Yes.
Higher. Okay.
If the fusional amplitudes are good, then there is a good chance that the patient will actually improve and the squint will get better post the LASIK surgery. So that was just one thing that I wanted to add. So there is a risk stratification that has been mentioned actually. Low risk, moderate risk and high risk. It's mainly for more concerning for patients with esotropia actually, the partially accommodative, but even in intermittent exotropia patients, the fusional amplitudes play a major role.
Okay. That's good.
Thank you.
And
Prachi, if
Yes,
the in after
orthopic
LASIK,
evaluation
if
before
there's
LASIK.
small amount of residual remaining, That's why it's better to do the LASIK first, you know. Sometimes they do, the full correction is not achieved, and then you still find that there is some amount of exotropia still remaining.
So the counter to it is sometimes we may have to add prisms post-surgery.
Yes, you may add
And the
that prisms,
patient
yeah.
has to go back to glasses. So
The problem also what I see after LASIK is that it's always important to do the squint evaluation, even if it is an exophoria in myopes. Because recently
pre-LASIK
even if there's
orthopic
no
evaluation
strabismus.
is a must.
Yeah, because I've and cycloplegic recently I had a patient referred with acute with esotropia with after LASIK, and they had overcorrected the minus. They're not done it along with the cyclorefraction, and so the patient went into an esotropia.
Yeah. So another point is the cycloplegic refraction
Yes.
should be within minus 0.5 adapters of what the patient is wearing. If the difference is more, again there is a chance of say either overcorrection or the patient having asthenopia.
It's a must.